why his T cells are not functional, we didn't know. But we did realize that is a bone marrow transplant may be the cure for this patient. There were no siblings. He was the third in the family. The previous two siblings had died. No one in the family to donate. There were no unrelated donors available for this child, and we ended up selecting one of the parents as a donor, because at this point of time I didn't know the inheritance of this genetic disorder for this child. So we ended up selecting father to be safe. What if it was an X-linked disease and the mother is the carrier of the gene? So we ended up taking father as a donor, and he had transplant using father's stem cells. Good engraftment on time, 100% donor comes on day 30, and then the same child, still the BMT unit around 1.5 months post-transplant, is completely changed. The skin has resolved, organomegaly resolved, lymphadenopathy resolved, and now about 3 years post-transplant and is well and cured of his disease. While he was getting worked up for the transplant, mother was pregnant, and she was pregnant by about 16 weeks. So they did discuss with us antenatal testing, but because we didn't know the genetic lesion at that point of time, we couldn't offer that. So we did explain to them the risk of continuing the pregnancy. Because we didn't have anything else to offer, the family chose to continue the pregnancy. And the baby was the fourth baby, the next baby after this was born. Because we were quite kind of suspicious with the next baby, we worked him up early. And as destiny would do, the fourth one is also affected with the same problem. He got the stem cells from father as well, and cured of his disease as well. We had taken, because he's a small baby, so we had enough cells stored with us, cryopreserved, and was treated with the same stem cells from the father and cured of the disease. Now, before transplant, his blood was stored, although we didn't know the genetic lesion, but the blood was stored. And one of the labs in Bangalore helped us with doing the next-gen sequencing on that blood sample. And what we identified that this child had a mutation in the interferon gamma receptor 2, and that was the pathology behind the whole T cell functional defect in this child, and also of the family, and would explain the phenotypic manifestation in this family. Autosomal recessive, but it was just quite I would say unfortunate that all the children back to back had had manifestation of the disease. So this is just a case to highlight that we need to with better diagnostic modalities, with high rates of suspicion, we can pick these children. We can pick the children and cure the children, and that's how we can make difference in the life of these families. Now, transplant, as we know, I think it was one of the MCQ questions we had earlier today, one of the quiz questions. It's not early, it was started in 1956, 57 on a patient with leukemia. There's a lot of pediatric, I would say, history. The first patient who had transplant ever was a pediatric patient for leukemia. The first non-malignant transplant was done for again a pediatric patient for severe KUMAR mutation in 1968, and that was done by what we call as the father of immunology, Dr. Robert Good, and that set the kind of the pace for non-malignant transplants. After that, 1968 was the first skin transplant performed. Now, indications of allogenic transplantation, I think we have discussed them by bits and pieces, but it's broadly malignant, which is leukemias and lymphomas, and non-malignant. And non-malignant is a big basket of disease. I think Dr. BIJU mentioned earlier about 30 to 40% transplants done in India or maybe elsewhere as well are congenital disorders, and immunodeficiency is a big group. Also hemoglobinopathies, which is sickle cell, thalassemia, bone marrow failure syndrome. These we're going to discuss a little bit later on in detail, and storage disorders. I briefly touch on these as well because it's again a group of disorders. Acquired disorders, aplastic anemia, paroxysmal nocturnal hemoglobin. This is not extensive list, but this is just a flavor of what are the conditions which allogenic transplants work. Now, the principles of transplant is broadly three: high dose chemotherapy and dose response curve, which we mainly basically employ in autologous transplants. Immunotherapy, which is what we discussed earlier, graft versus leukemia, the graft versus tumor, the graft versus disease effect, and that's what called the LO effect, and works in malignancies. But what works in these genetic disorders or congenital disorders is gene therapy. So the transplants works the gene therapy. So you replace the defective gene with a normal gene from the healthy donor, and this is kind of allogenic gene therapy, which is different from autologous gene therapy, which we otherwise the true gene therapy is autologous gene therapy. You correct the gene in the patient cells itself and give it back to the patient. But here we are using the allogenic cells which have got normal genes to replace the defective gene in the patient. Now, don't go into the, you don't need to remember the names or the genetic lesions in each of these, but I just want to tell you that severe common immunodeficiency, whatever the cause, whatever the genetic lesion is, Wiskott-Aldrich syndrome, a transplant is going to be curative. Infantile malignant osteopetrosis. Again, I've seen a few of these I think in South India because of more consanguineous marriages. We see a lot of these kids with osteopetrosis. These are the common mutations which can lead to osteopetrosis. Transplant can be curative, but we have to remember there's one mutation, which is OSTM1, which can be less than 5% of the patients, but transplant doesn't work there. So we need to identify that less than 5% patients who transplant may not be effective and may not be curative. Now, storage disorders, some of you, who probably still are in training, and when you read about storage disorders in our textbooks, we read that enzyme therapies are the frontline therapy, and that's true as well, because you have a deficient enzyme, we replace the enzyme and they're cured of the disease. Not cured, you have controlled the disease and they will have a normal, healthy life, and they as any other normal individual. But the problem with enzyme therapies is that one, they're not available or they're too expensive. So to sustain a patient on enzyme therapies throughout his life is practically impossible. Enzyme therapies can cost you 40 lakhs to 1 crore, depending on whatever enzyme you're talking about, every year. And to have that much of support for any patient is practically impossible. So that is why I think bone marrow transplant can be an alternative to enzyme therapies. Want some of these storage disorders where we may not be able to afford or have an enzyme available, transplant can give them a long-lasting cure. But we have to remember that these storage disorders, some of them will be cured or will be helped with bone marrow transplant, some of them won't be, and that's what I have put it here. Proven benefit, for example, MPS 1, which is Hurler syndrome, the transplant does work. MPS 2, Hunter, it really doesn't work. So it's important to classify them into the conditions, in the group of patients where the transplant can work and transplant doesn't really help. Same for lysosomal storage disorders. Gaucher's disease, a common pediatric genetic disorder, storage disorder. Type 1 and type 3, we know that transplant will help. Niemann-Pick, aspartyl amalgam glycosiria, here the transplant will work, but some of them like Gaucher's type 2, Fabry's, the transplant doesn't work. So I think, again, to highlight that we need to know and label them correctly and then offer transplant as a treatment option. X-linked ALD, X-linked adrenoleukodystrophy, a common problem. We have got 2 patients at this point of time having transplant X-linked ALD. Metachromatic leukodystrophy, but some of them it has doubtful or no role, so that's what we need to kind of understand. Now, another big group of disorders is macrophage and granulocyte disorders. Primary HLH, I think we have got better and better at identifying HLH in the last decade or so, and most of these HLHs which used to previously be labeled as secondary, with the availability of better workup facilities and access to the genetic workup, most of them have turned out to be primary HLHs. Congenital neutropenia, leukocyte origin defect, Shiraki-Gashi, chronic granulomatous disease, Wesley syndrome. These are tongue twisters, and believe me, although we feel that they may not be that common, but we do come across them on and off in the clinical practice, and the transplant is probably the only curative option for them. Bone marrow failure syndrome, we'll hear that more in the next talk. So these are again a group of genetic disorders wherein transplant helps. Now, a little bit more about the primary immunodeficiencies. As I said, it's a very heterogeneous group. It's not a one disease group. There are more than 200 genetic lesions identified to give rise to primary immunodeficiencies. They can be X-linked, they can be autosomal recessive, they can be autosomal dominant, and they can either lead to a missing enzyme or some kind of protein missing, and which can lead to dysfunctional or altered signal in one of these immune cells and gives the phenotype. Now, all that's not in the scope of the talk today, but we need to also, as a students or as practicing hematologists, we also need to understand when we should really suspect immunodeficiencies. And we were just having some survey done last year, and we estimated that probably in India 1 lakh children with immunodeficiencies are born every year. which is 5 times the burden of thalassemia. As we heard Vikram saying, 20,000 children with thalassemia born every in India, and we estimate 1 lakh children with significant immunodeficiencies born in India every year, which is the large burden of disease. But because we never identified them, we used to keep them, we would put them in a basket of, sepsis, disease not being diagnosed, and most of them would succumb to the disease without we would identify the cause. But if we have high dose of suspicion and try to understand when to suspect immunodeficiency, I think now we are better at picking more and more of them. So, if you have got a recurrent infection, I don't know the detail of this slide, but if you've got recurrent infections with atypical organisms or invasive fungal infections, someone having inflammatory bowel disease, autoimmune disorders which are kind of atypical, chronic diarrhea, these are the symptoms, or these are the manifestations where we need to suspect immunodeficiencies. And immunodeficiency is a mixed bag, as I said, can range from gamma immunodeficiencies, T cell immunodeficiencies, B cell immunodeficiencies, DNA repair defects, phagocytic defects, and other syndromal defects. And broadly, it's divided into these two groups. So one is the B cell functional group and the phagocytic functional group. Most of these B cell functional disorders can be managed just by immunoglobulin therapies throughout their life, but the ones which are more severe are these T cell defects and the severe gamma immunodeficiencies, where transplant is the only curative option, of course, in addition to the gene therapy which is in the pipeline as well. Now, what are the differentiating features? How does a transplant in a primary immunodeficiency differ from any other transplant? Like we just discussed, we had discussed thalassemia before, and we discussed autologous transplants before, and we're going to have some other discussion later on with the malignancies. One is that these are highly heterogeneous patient groups. As I said, it's not a one disease. We have to tailor our treatment and strategy to each and every patient, and preferably transplant in a center where there's experience in transplanting these type of children. So what are the differences pre-transplant? Most of these are sick babies. So how we diagnose them? Because they are infected, they have got atypical infection, that's how we suspect them. So most of the times they're sick. They may be carrying viral infections, especially CMV, EBV, adenovirus, and maybe some other other infections, invasive fungal infections, pneumocystis infections, very common. So they may be already infected, they may be sick at the time of diagnosis and at the time of transplant as well. Young age, most of them are younger infants. So that puts them at a higher risk, and also of some consideration we should take into consideration when we are transplanting those small babies. Sometimes highly sensitized. We heard Dr. Vikram saying about how sensitization is important when we transplant thalassemia. Same thing applies for some of these immunodeficiencies as well. For example, you've got a patient with Viscott Aldrich. He has been transfused platelets throughout his life. He's platelet refractory, has got sensitized with a lot of these platelet transfusions throughout his life. Donor selection. So I gave an example of this baby which we showed in the case presentation. We need to understand who the donor is. The sibling donor, we have to make sure that the donor who we are using as a donor is not affected with the same disease. Parent is not carrying the gene and may or may not be able to know it. So that's something which we need to take into consideration. Sometimes, although we don't have the luxury of that in India, but sometimes some of these patients may need some preparation before going into transplant. For example, with a patient with ADA deficiency, they can get PEG ADA therapy before they go for transplant, so that they're optimized in a better shape before they get to transplant. There is some consideration to conditioning as well. It's not, we know that, for example, we discussed autologous transplant in a lymphoma being as a gold standard. But here, we have to take a lot of tailoring of the conditioning, what you're going to give them. Because it's based on the diagnosis and the clinical condition of the patient. It's based on whether it's a matched sibling, mud, or a haplotransplant. What type of transplant you're offering this patient? What type of source your stem cells, marrow, PBS, or cord, what are you going to use? Whether you are able to use myeloablative conditioning or a reduced toxicity or reduced intensity conditioning. So based on these parameters, we need to tailor, we need to choose an appropriate conditioning regimen to this particular patient. For example, cyclophosphamide we don't want to give in a patient who's in an infant because of the high risk of VOD. Some of these immunodeficiency kids who are, we call them T negative, B negative, NT negative, may not need any conditioning at all. So you just simply give them the cells from the donor. Radiosensitive disorders like DNA ligase deficiency. So they're extremely radiosensitive patient. So what we do them is that you When you give them alkylators, they give a very, very small dose of alkylators. For example, in phencylanemia, we give a very, very small dose of alkylators. Same thing happens in these kind of disorders as well. So the point I'm trying to make is that when you choose a conditioning for a patient with immunodeficiency, lots of things need to be taken in consideration. When you choose a cocktail of conditioning, and there are guidelines available. This is one of the guidelines which is from the American group working party on immunodeficiency and involvement of metabolism. So they have given some guidelines based on whether you want to use a myeloablative conditioning or you want to use a reduced intensity conditioning, and what are the different options available. And of course, these still need to be tailored as per the as a patient condition and the patient's disease. Now, I think we can touch this briefly, and this is something which we have been also doing in the last few years, is when we do haplotransplants in immunodeficiencies, we know that use of cyclophosphamide may be too toxic for them. They are small babies, infants, cyclophosphamide may be toxic, and there's a high incidence of BOD using cyclophosphamide. So we and some other centers and have been also using haplotransplant using T cell alpha beta depletion. I don't know the details of that. We're about 50 of these procedures now. It's simply what you do is that you pass the product. This is the PBSE product. You pass it through a system. It's a Milteni system. It's a magnetic bead separation.